Okay. I wanted to give everyone a little quick webinar on uh, excuse me, on cardiovascular disease today, and that the language that exists out there does not really fully express um, the ability to reverse cardiac disease. And so, as we all know, there's primary, secondary, and tertiary prevention of disease, but we apply that exclusively sometimes to cardiovascular disease. So, primary prevention is preventing it much earlier in the course, so it never even becomes a diagnosis, and that's really the primary goal here. If you make it to your middle years and later years, you likely have some level of cardiac disease, whether it's some mild calcifications or plaquing of the arteries. And the goal would be to never let that become significant enough to become dysfunctional, where you'd have disease from it from a cardiovascular perspective, where then we'd only be managing symptoms such as secondary prevention. And so when you go from no disease and we're trying to prevent any onset of dysfunction, that's primary prevention. When we get to having some diagnosis, whether it's hypertension or hyperlipidemia or coronary artery ischemic cardiac disease, where you've had a stent or an intervention, or you've been diagnosed with congestive heart failure, then we need to monitor that and reduce it and put you back in the reversal zone. So we may even eliminate that off your list. If you've already had significant intervention and now we're just managing symptoms from a failing heart, now we're into what's called tertiary uh, uh, prevention and trying to prevent recurrent events, because it's the recurrent events that people do not come back from. And so significance at every level, but it's much better to start as early as possible to prevent the cardiac illness. So reversing cardiac disease is the title of this, but I just need to lay some foundations down here, that this is the functional lens that we look through in this clinic, but we don't ignore good cardiovascular literature as well. And I say good because there's some bad stuff out there. There's some bad practices, in my opinion, that do not give people favorable outcomes or optimal opportunity to reverse their disease. So I think we need to look a little deeper than this. I've recently taken what's called the Bale-Donine method from a cardiovascular reversal disease process. As you all know, I work closely with Chris Stevenson, who's the integrative cardiologist in the south side of Charlotte, and we collaborate frequently. And if we need to, we can get you down to see him as well and get his expert opinion on this. But this is Heart Healthy Month. I'm catching it at the tail end of the month, but I want to get this out to you because this is important. And we don't want to miss something. So if I say something in this video that catches your eye or your ear, then bring it to my attention, because we need to do a deep dive then into figuring out how to put you at a better stance, a better platform, a less risk, and identify anatomical disease early. So, I'll just say this. There are people out there, their cholesterol's normal, okay? And 50% of heart attacks and strokes have normal cholesterol. I have a friend recently who had a stroke. His cholesterol was fairly normal, and his calcium score from a CT scan, as you all know, that we encourage people to get, was also fairly normal. But he had a burden of soft plaque that lodged upstream into his brain from his carotid artery and caused some occlusive disease and caused a stroke. So we want to make sure we investigate this fully, because basic lipids are next to worthless, guys, right? You've heard me say, quoting Dr. Robert Roundtree, it's 1970s medicine, this cholesterol-centric idea of approaching cardiac disease. So it doesn't mean that we don't get lipids, but we get advanced panels and we get advanced risk scores, and we put you into risk calculators. And then aside from the risk, we look at the anatomy with the CT calcium score and the carotid IMT testing that we're going to have done in this clinic. And we're trying to coordinate patients and ourselves to fly these people in to have this performed here in our clinic. So I'm going to move on here, but I'm going to move through this PowerPoint and skip some slides because of time. But, focusing on the cardiovascular system is everywhere, not just the heart, as we know. It's in the brain, it's in our peripheral extremities, it's in our sexual organs. And I'll say this, if somebody has erectile dysfunction, that's categorized or classified as cardiovascular disease. Because if you have vascular problems in your toes and in your feet and in your lower extremities and in your penis, you have disease everywhere. Okay, so we're going to do some investigative work, and this needs to be aggressively approached, because this is the number one killer. This is the one that can cause major disability and dysfunction, particularly in these years right after retirement, or these years around retirement, or if we're trying to finish strong with our careers. So we all know somebody that this has happened to. So every 39 seconds, someone has a heart attack. We don't want that to happen to you. So if you can plug in here and listen to some of this, I'm going to give you some tips on what we might have missed with your evaluation, or that we can offer to further investigate deeper and give you a better full-rounded evaluation of your cardiac status. So I want to mention one thing of cholesterol one more time, is when you look at those people who have heart attacks and those who don't, there's an 80% lapse of cholesterol. So 80% of those people all have the same cholesterol, whether you have a heart attack or you don't. So how predictive really is it? So I'm going to mention 3 things that I want you to keep in your head here as we move through this, because I'll probably bring you some more cardiovascular or metabolic health blogs in the future, but this is really more of a webinar due to the length of it. But when you think of 3 things to focus on from a cardiac disease standpoint, we think of number 1 is oxidative stress. So your cholesterol doesn't form plaque unless it gets damaged or oxidized or changed. The 2 biggest things to change that is, number 1 is environmental toxic environment pollutants, and number 2 would be blood sugar. And so blood sugar can attach onto lipid particles and change them. When they change them, our immune system gets activated and becomes part of the process, and now you're going to cause this inflammatory reaction and lay down plaque in the arteries. So oxidation, inflammation, and immune dysregulation. And if I were to tell you one thing, I believe that cardiac disease is an immune-mediated process. You could almost call it an autoimmune disease, because if we keep feeding it the same triggers, and we keep eating the same stuff, and we keep bathing ourselves in the same environmental toxins, we're going to turn on this cascade. Whether it's premature or not, we're going to do that. I'll talk about genetics down the road. But I like to bring up this Simon Sinek's golden circle just to say, look, you're not just here for you. Your why is different, right? It's not what you need to do or how you need to do it, but really why is what drives the behaviors. So if people depend on you, if you need to show up to work and show up at home and be present and healthy and be able to serve your community well, then this is much more about just your health status. And so I want to be clear on that. What you mentor for your children and your grandchildren and your friends and family and community matters, and that should be everyone's why to an extent. Okay, so there's a lot of missed heart attacks out there, right? There's greater than 50% of the heart attacks leading to sudden death happen in people with normal cholesterol. So American Heart Journal in 2009. So the first clinical sign of cardiac disease is sudden death. That's the first clinical sign someone finds out that they have the disease to begin with. Wouldn't you agree that that's much later than we would like to find out? So I'd like to find out through an advanced functional assessment, an integrative assessment, just like they do at Vanderbilt, just like they do through Mark Houston's workups. just like Chris Stevenson would do, and offer a very well-rounded approach to identifying illness and disease early and risk early so we can prevent finding out while someone's pumping on our chest with chest compressions. So most heart attacks happen with less than 50% blockage of your artery. Let me just say this. Stress tests don't even show that they're positive until there's greater than 70% blockage. So it's not well known as a great screening tool because of that, because most of the heart attacks happen with less than 50% of the coronary occlusions and stenosis. So, so we want to investigate these things because it's not all what people think. We want to really investigate down. The conventional world looks at about the top 5 risk factors: smoking, diet, exercise, cholesterol, and blood pressure. The rest of the things like homocysteine and uric acid and what's my dental hygiene look like, the bacteria in my mouth gets into these coronary plaques. And so it'd be nice to know, well, do I have those bacteria in my mouth that is creating this oxidation and inflammation? Remember the 3 top things: inflammation, oxidation, and an immune dysregulation. If I have these triggers in my mouth, I want to know about it so I can change it and improve it. What are the genetics? We can test your genetics to see if you're at risk. So these are just some stats, right? This is that every 25 seconds in America, there's a coronary event. Every 39 seconds, someone dies from a heart attack or stroke. So this is horrible in a country that has the best care, supposedly. This tells you that we're not doing a great job knowing that this is the leading killer, okay? We need to improve our heart health, our vascular health. We need to really get a handle on this. This is much more than the top 5 risk factors. There are 400 risk factors. We always approach the top 25 minimally, and then we dig deeper depending on your willingness to dig deeper. And I'll tell you, some people will guarantee your results if we dig deep and do this. The Bale-Donine method that I've been trained on takes a deep dive into all of these things, as well as my functional training under Mark Houston. So I'm going to move through some of this and move you into, how do we determine your cardiac disease risk? How is it determined? My doctor says this, Dr. Woodward, you're saying something else here. I've been led to believe that I've been doing everything I should be doing. Well, I'm going to tell you, you haven't. I didn't learn this stuff until after I was out of residency. So I had to do all this postgraduate training to understand how do we appropriately establish risk. And I'll tell you, this was new information to me. I did multiple rounds with cardiologists and preventive cardiologists and interventionalists. And so most of the lingo I heard was put them on a statin, you'll be okay. There's a cardiologist that belongs to the gym where I work at. I was asking him some of these concepts about oxidative stress and inflammation, and he just dismissed the conversation and said, John, put him on the statin, everything will be okay. I'm going to show you here that's not okay. That's bad advice. You will miss people because it doesn't address all of these concerns. It doesn't address the 400 risk factors. It doesn't address some genetic variability. Everybody is different. I think you all know that. And so the common risk calculators are: we look at your age, we look at your gender, we look at your race, we do look at your cholesterol panel. It does factor in, but not how you would typically think. We want to know if you're a diabetic or a smoker, or whether you have blood pressure. I use one called the Reynolds calculator, which is what Dr. Stevenson uses. If you happen to have a calcium score, we use the MESA score system because it incorporates some of the diagnostic tools that we've obtained. And so there's also another one called a Rasmussen score, which I like a lot as well. And so when we apply these diagnostic calculators, they do give us some reliable risk. And what is your future risk of having a significant coronary event? So it's important to identify things, but this is what the general public focuses on. We miss a lot of other pieces. And so I thought this was very interesting. Now, this is back in 2012, the New England Journal of Medicine, where they looked at some of the diabetics. And what we found was, and with these diabetics, the standard treatment typically is let's get your hemoglobin A1C down no matter what, even if it means more insulin. Well, we know that insulin increases weight. We know that insulin increases cancer. We know that insulin increases heart attacks and strokes and other things. So my goal is to reduce the amount of insulin that you need to either inject or that your body produces on a daily basis, because it contributes to these things. And yet that is not how it's being handled in the conventional pathways. So there's a continuum, whether it's insulin resistance or heart disease. We want to move you back up to that, toward that wellness continuum with primary and secondary prevention strategies and identifying things, and then telling you, well, what will reverse this process? I do have plaquing. Maybe your calcium score was elevated. Maybe when we do obtain the carotid evaluation, and it's not the carotid evaluation that you're thinking of, it's called a CIMT test, a carotid intramedial thickness test. And so that one's going to tell me about your soft plaque and the thickness of your artery wall. And so we need to know that information in addition to the advanced lipid panel, in addition to inflammatory markers, in addition to oxidative stress evaluation. And so we can evaluate that through a lot of good questioning and answers, surveys. So let's look at the progression of cardiovascular disease here. So if you look at, and I don't know if you can see my pointer here, but if you look at the far left side of this vessel, you see how that lumen, the pipe, is wide open. But over time, as it progresses, you see that wall of the artery thickens. And then there's the addition of calcifications. These calcifications, and sometimes the plaque even has calcifications in it in here, and even the thrombus may even have some calcifications in it. So you see how this is thickened. That's a diseased vessel. That's what the carotid IMT will evaluate, is how thick is your vessel per age and per your age cohort. We also want to look at the calcifications in that artery wall. The CT calcium score will help us identify that as well. In addition to that, then we look at damage, disease development, vulnerability of the plaques with those markers in your advanced lipid panel. So we're going to be evaluating those in addition to the studies that look at your anatomy and the blood vessel walls and the heart. And of course, that CAT scan also gives us some more information. Do you have an aneurysm in your chest? Well, we have found one of those with a couple of our patients. Do you have a lung nodule or something else that's a little bit odd? So we can pick quite a bit of information up and give you a pretty good assessment. In my opinion, probably the best assessment when we add in the functional lens to evaluate this. So, right, the common lingo is, what if complications develop from statins? Don't worry, the American College of Cardiology guidelines are going to find a way around that, because it's based on the cholesterol-centric pathway. And so the statins worry me because I believe there's a lot of unneeded statins prescriptions written. It does not mean that I am completely anti-statin. I think there's a place for them, but I believe we overwrite them, and the doses that we write are not necessarily proven out in the literature, despite some guidelines. And I'll show you some disagreement in some of the guidelines. So we want to identify high-risk individuals, and then in terms of the basic guidelines, because it makes it easier for doctors. What dose of statin do I give? Do I give a statin? Do I not give a statin? Well, I'll just tell you, the main focus is on statin therapy in the conventional model, but the statins do cause a series of other problems, such as low testosterone, the increased risk of diabetes, Alzheimer's, causes multiple nutrient depletions, but in addition, erectile dysfunction, gynecomastia, which is a feminization of the male breast tissue. There's more depression. There's more dysfunction. There's something called mitochondrial dysfunction, that it lowers our energy pathways. And so if your energy is already low and you add a statin to it, I wouldn't expect a whole lot of improvement. And so we have to be more discerning with who gets a statin, who doesn't, and at what dose. And so the nutrient depletions from statins are many, and these are very significant. If you reduce your vitamin K2, you can increase your risk of calcifications in the arteries. If you decrease your risk of selenium, one of the most powerful antioxidants, and CoQ10 and vitamin E, vitamin D, all of these things, even if you have transient depletions day to day, week to week, month to month, that can impact your overall health status. And so, there's evidence that cannot be denied at this point. It's in the American Journal of Cardiology. There's definitely an increased risk of blood sugar dysregulation. Well, we just talked about insulin causes increased pathogenesis and the progression of plaque into the arteries, atherosclerosis. So statins are not great for everybody. They may actually increase your risk. So independent, statins can promote coronary arthromas and calcification. So this actually says, wait a second, they can actually increase things. And, so is it regressing or is it progressing the atheroma? There's evidence on both sides of that panel. But look at this, the American College of Cardiology, which is the guidelines that everyone looks to sometimes for these recommendations. You will see that men older than 65 with no other risk factors, the new guidelines recommend statin therapy. No risk factors, but let's put them on the drug that causes all those other effects. The Mayo Clinic says there's no evidence to really recommend this. If you look at the primary prevention in high-risk patients, they first recommend statin therapy, high dose, and then encourage healthy lifestyle habits, as opposed to Mayo Clinic saying, let's start with lifestyle and let's dig in deep with that because we may be able to avoid some of these other medications. Again, all diabetics over the age of 40 with the American College of Cardiology recommends statin therapy. The Mayo Clinic does not recommend for or against statins for that age group. I think they leave it up to the practitioner to make wise choices based on the lifestyle and other risk factors that they're evaluating. Remember, they're still looking at only the top 7 risk factors. We're going to look at many, many, many more. So this is where I think I like the Mayo Clinic guidelines better. With autoimmune disease, you're at much, much higher risk, even than a diabetic, to have a coronary event. And so we need to be careful with that. And statin therapy may or may not be appropriate at that level. But again, I think that's where we at least need to consider it if there is some obvious disease present. Lipoprotein little a definitely should be looked at. It's an independent risk factor for coronary artery disease and events. It's not looked at in the ACC guidelines from 2013. So definitely should be looked at. My feeling is it will be added to the ACC guidelines in the future if it's not already, but we look at that. And so I'm going to move through here, and I'm just going to tell you, look, this is a reversible disease. We just don't manage the disease and slow the progression. We can reverse the disease. It is preventable. It is controllable, okay? How much do genetics play a role in this? I'm going to tell you that genetics, depending on who you read, Mark Houston out of Vanderbilt will tell you it's probably 20%. Mimi Guarani might say it's up to 30%. Some studies say up to 40%. So based on the two people I respect most in this field, I'm going to say 20 to 30%. And so we need to figure out, and we have the ability to assess your genetic, not only your genetic predisposition for the disease, but also your genetic expression of the genes you have. So there's 2 tests that we can do to evaluate that 20 to 30% of your risk. And I recommend, those of you at high risk and those of you that are progressing, that we look at those, because it may change some of how aggressive we get with your plan. So there's this condition called epigenetics that some of you have heard me talk about. And I'm just going to tell you that the Amish have a gene called the obesity gene. It's called the FTO obesity gene. It's probably the strongest penetrance gene out there that can influence weight. And here's the thing: most of the Amish kids are thin, and so they're not all obese. In fact, the Amish have less body weight and less BMIs than the average adult population, or the average population in our country. When you look at 65% of us are overweight and moving into the 70% range. And in the Southeast, it's even worse. It's closer to 75 to 80%. So we live in an area that those stats don't apply to us. It's even worse. It's the worst in the Southeast United States. So These people overcome their genes by suppressing them so they don't get expressed. And they overcome them with lifestyle, with exercise and diet and wellness and whole foods and fruits and vegetables. So this is, the Archives of Internal Medicine back in 2008 published this study. So lifestyle is critical. Here's where I said genetics is only 20 to 30%. Lifestyle is the biggest piece of this. Okay, so we can really reverse the disease. It's not just my parents had it, therefore I will have it. That's not how it works. So your gut plays a big role with cardiac disease. I'm not going to get into that today, but I'll let you know that managing your gut health does, and there's studies out there that show it increases a risk for coronary artery disease. There's more cardiac events with poor gut health. The toxins you bathe yourself in, what you eat, what you drink, what you swim in, what you put on your body, lotions, cosmetics, all play a role. The cleaning supplies in your home, the Scotch guards in your house, all of those things play a role. With the oxidative piece, remember the three things: oxidative stress, inflammation, and immune dysregulation. All of these things promote oxidation of your DNA, of the particles in your blood vessels. They can damage the ability for the cells that line your arteries to be dysfunctional. Air pollution, type 2 diabetes, heavy metals, and abnormal blood cholesterol, dyslipidemia. Again, just more and more, it just goes on and on. There's a lot of this stuff out there. So, as long as you take your medicine, cardiovascular disease is not a big deal, right? My doctor has me on my blood pressure med and I take my statin. What else do I need to do? Right? Those people are still having heart attacks and strokes at an accelerated rate. And so those medicines are not saving them. Those medicines are not protecting them. And so, these people are still getting the weight gain and the vascular disease and the heart attacks and the strokes and the eye disease from the plaque in their eyes. They're still fatigued. The medicines cause fatigue. The weight gain causes fatigue. There's all kinds of things that, not only diabetes and cardiac disease do, but we need to really plug in and look at the appropriate ways to manage this. And so my point with this slide is most of cardiac disease is not in the pipe blocking the blood flow. Most of the disease is in the artery wall years and years before that thrombus breaks off and plugs downstream and causes stenosis. The progression of disease, the lumen of the vessel tends to be normal. So remember, up to 70% of heart attacks have less than 50% blockage of the artery. So very significant that we understand that. Unfortunately, in this country, we don't start moving on something until the disease and the problem is already here. Harder to reverse and improve that artery wall than these two artery walls previous to it. So we need to be artery focused and lumen focused both, but artery focused is where the primary and secondary prevention takes place. So if we don't pay attention to it, we end up with a lumen problem, and that tends to be more of a tertiary, third level prevention where we're just trying to prevent further heart attacks and strokes. That's not where I want to take you. I want to partner with you to reverse this much early on, and so we can get to the heart of the matter. I didn't mean to make a pun out of that. So large proportions of patients with high cardiovascular risk have unhealthy lifestyle habits. We need to improve the cardiovascular prevention methods. And I suggest that exercise and diet, of course, play a big role. So what's the primary diet? Plant focused. My quote that I like is, nobody reverses disease by eating meat. Everybody reverses disease by eating plants, particularly cardiovascular disease. So great books on there. How Not to Die by Michael McGregor. Joel Fuhrman is Eat to Live. Esselstyn Campbell with Dr. Campbell and Dr. Esselstyn with Forks Over Knives, and the China study. And there's a lot of good information out there about how to really reverse this disease, but plants are absolutely king in getting to this process. Looking at animal versus plant protein, there's cardiovascular mortality studies on that. High animal protein was positively associated with cardiovascular mortality versus plant protein. We have other emerging risk factors. What's in the gut, what bacteria is in the gut can increase your risk of some of these things. This gut barrier does matter. It increases inflammation in the body, including the blood vessel. What I eat activates the inflammation in the immune pathway. Remember, inflammation, oxidation, and immune dysregulation. It starts with what I eat. All of these pathways get turned on with these emerging risk factors. So, medicines don't work in people who don't take them. So when you look at the data on people and their adherence to all the medications, whether it's a cost burden or just pill fatigue, only people with blood pressure only take their medicine about 68% of the time. So it doesn't work, right? If everyone took it, certainly I'd be a fan of that if they decided not to take any lifestyle measures. But this is 2016. Family Practice News, discussed this. So we need to make sure you order the right tests. We need to use functional status, not just reference range status. We need to look at the 400 risk factors, not just the top 5. You're going to be missed. And if you're missed, they're going to manage your disease late stage, not early stage. And so, we want to order all the correct tests to determine what's going on in the lumen and the artery wall, treat your body as a whole, and do this the correct way. So we want you to be proactive, okay? We want you to be involved. We want you to dig in and partner with us and transform your health together, get some coaching, attend these classes, have more dialogue around this. We want you to look at not only the genetics and the nutrition and the hormone evaluations. Hormones play a big role in cardiovascular prevention that I didn't dig into today. Really drill down on the cardiometabolic health, particularly diabetes and insulin secretion. Clean up your environment, because the gut plays a role. The toxins play a role with the oxidative stress and the inflammation piece. And so we put it all together. So, my point to all this is that we need to focus on your heart health. And it's Heart Healthy Month. It's time to dig a little deeper. It's time to show that we want to keep this. This is one of the vital organs of the body, that the heart, the brain, the kidneys, the liver, significant. And so it's amazing that it doesn't cost anything. We have to eat. We need to move our bodies through space, and we need to push forward on this. So anyway, I hope you enjoyed this. I hope it shined a little bit of light on some ideas that maybe you weren't thinking about. And if there's some testing that I talked about that you want to pursue with us, reach out to us. If you want to know more about these 400 risk factors, we can talk about those later. I'll probably dig into those later with some other topics. What I'd really like to do is break down the oxidation into a lecture, the inflammation into a lecture, and the immune dysregulation into a lecture, so you can break these down and say, okay, let's target those 3, since those are the 3 things I should be focusing on. So I wish you well, and as we wrap up Heart Healthy Month, I'm hopeful that you all will be more proactive with your cardiac health. Thank you, and we'll see you next time. Thanks, bye.